So I'm just really excited. As we gather here today, of course, I want to start by acknowledging that we, Evelyn and myself, are on Treaty 6 territory and the homeland of the Métis. And we pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Now, I'm sure there's many of you who are here from beyond Treaty 6. Feel free to, in the chat, post which treaty territory you're on. We'd love to see where everybody is from. I'm Carrie Catherine, and I'm the coordinator of Reconciliation Saskatoon, and we're really excited to present today's event with our partners, the Saskatchewan Cancer Agency and the Division of Social Accountability at the College of Medicine at the U of S. So we are recording today's webinar and just wanted to let you know, oh look, we've got Treaty 4, many Treaty 6, Treaty 1, excellent. So we are recording. The link will be made available to everyone who registered sometime next week. And then you'll also notice that we have closed captioning available. And so you can find that at the top of your screen, and you can turn it on and off yourself. If you need any instructions on that, just let us know in the chat. We are going to leave the chat on all throughout the presentations, but we will have a few moments during the program today to have question and answers. So feel free at any time, though, to post your questions in the chat, and we'll be watching for that. And of course, there's a lot of diversity in our gathering here today. There's so much that we share and different ways that we see the world based on our different locations. So in order to foster a safe space to share and learn, I'll just mention that if there are disrespectful words or behaviors on this call, then we will politely exit you from the call, but we're sure that that won't happen today, as we're all here in the spirit of learning and growing together. So it is my pleasure to actually be in person with someone other than my dog today, and that is our knowledge keeper, Evelyn Linklater. I'm just going to shuffle you over a little close to her so that she can open our event in a good way. There you go, Evelyn.
That's it. Welcome, everybody. I gladly and humbly accept this tobacco that was given to me to open the prayer with a prayer. So that's what I'm going to do in my language, which is Cree, to honor the Creator that gave me this language. And for you that are here, you can follow me in your own way, the way you were taught also, to honor you and honor the Creator. I will now start for a blessing for all of us here and everyone that come and live with us from other countries. We welcome them with an open heart, so they will also live with us in harmony with the nature of everything that goes around us, that loaned to us from the Creator. Because everything is loaned to us. We don't own anything. We don't even own our lives. The Creator can take it away anytime. So that we have to honor that every day and give thanks. And I will now start in my own language to give thanks. Auno tawinan kisiman to sa widiminan at also mo tagamama wiyak sa widiminan sa wasamisnadag no seminana gagawin at pugitiw sa piwit sa amig wak sa widimiksiman to kinanas kumit na niya wiyak anong skagi sa gagnis na iwamin niya wiyak o tagap nimitsiwagan na gagitan yung mga bumagan na kisiman to Pete sa ultimo suminanak na piwit at miguwa ko nung sumo taga mama waya kaginamina nung umina nakaginamin so sa misna nagagilaw nagagiinigan nung tagwag na piwit sa kapawis na ako pawis na kung tamakan nung sa pag-usid na megawaya gutaski. How mo tawin na nas kumit na hindi nga giwag na magta sa ako na niyaw winat ni Ma'am Tunidit sa ganda kasi man ko. Igatawa ni Kiskisi ang nisa na tigitiya uyan, kung sa tutama kay sa pag-usili magawiyan, ang nung tawin na, iyakukan ko tamaga, kagilaw sa win na may kukutaw ni Gani, o kung sa tutawa, o sa kay sa pag-usili medyo. Ang nung tawin na, isagit na, isagaya, dis na, tagisiwat siya, guys, tagisiwat siya, guys, tagsiman to. Nanas kumit na, igusipit tamat, ay, iguse, nanas ko mo na hindi naman sa nagniyaw nagsiksiman ko. Nanas ko mo na. Ay. Thank you.
Thank you, Evelyn. So now I would like to introduce Dr. Preston Smith, Dean of the College of Medicine at the U of S, to make a few remarks.
Good afternoon, everybody, and certainly welcome everybody here. Very pleased to see the amazing turnout for this afternoon's presentation. So I'm Preston Smith. I'm the Dean at the College of Medicine. I'm situated here today on Treaty 6 and the homeland of the Métis, although I often like to add that I spent 90% of my life in the homeland of the Mi'kmaq people of the Maritime provinces. I think this event, the knowledge shared and the discussions generated are going to be so important to where we are now and who we want to be as Saskatchewan's medical school. Our college and I as Dean are committed to being a leader in anti-racism, equity, diversity, and inclusion within medical education and research. I joined a number of national meetings this last winter and late fall on racism in healthcare in the wake of the death of Joyce Echaquan. The accounts of racism in healthcare were profound, painful, and I know from 40 years in healthcare education and clinical care, all too true. It was particularly distressing to hear an Indigenous medical faculty member in Winnipeg tell of her daughter, who's currently a medical student, experiencing the same racism in medical school as she had. In a totally different meeting here in Saskatoon, I heard almost the same words from one of our Black medical faculty. For our college, the reality certainly is that Indigenous learners and others experience racism here. So I want everybody to know I understand, and we as a college understand we have a long way to go. We must change significantly, have difficult conversations, acknowledge different things about systemic realities within our college. We're not very far along this path, but I do believe we've started. Our Division of Social Accountability, hosting this event with the Cancer Agency, is led by Dr. Manuela Valle Castro, who brings great expertise in anti-racism and EDI to her role in our college. The division has been hosting a regular health equity series, supporting changes on curriculum and on admissions, as well as leading collaborative strategy for anti-racism and anti-oppression training for faculty and staff across the college. This very day, our Indigenous Health Committee and many allies and other partners are working toward the creation of a division of Indigenous health in our college. Certainly, it's our hope this division will solidify and enhance an environment where Indigenous learners feel safe and welcome, and won't say the same thing about the next generation of medical students. We established a division of an inclusion working group, and recently 42 people volunteered to join that group. They include students, grad and undergrads, faculty, staff, both our Saskatoon and Regina campuses, and throughout the province. They are going to look hard at implementing the University of Saskatchewan EDI strategy and action plan. Last year, we hired Dr. Aaron Prosser-Luce as the college's senior EDI specialists. And there's a weekly EDI newsletter, a new college EDI webpage, and the development of a new EDI survey to be issued to our college community next month. This data will help our working group move many initiatives forward. So we're making progress, but as I've said, we have so much more to do. Anti-racism and EDI are incredibly important focus for our college. It requires our full commitment and effort now and well into the future. So we must make changes to ensure there is a real equity of opportunity, diversity across our full team, and respect for one another. Thank you.
Thank you so much. And now I'd like to introduce Dr. John Tanita from the Saskatchewan Cancer Agency, who is going to introduce our featured speaker. So take it away, John.
Thank you. Well, I'm really pleased to have the opportunity to welcome you all to today's learning event on behalf of the Saskatchewan Cancer Agency. It's really encouraging to see the amount of interest in today's event. I think right now we're almost at 230 people, so that's really fantastic. But you know, racism is not an easy topic to discuss in healthcare, but we need to be willing to set aside our discomfort and have these tough conversations. Patient and staff safety really depends on it. Our executive team at the Cancer Agency is committed to doing what we can to support staff in learning learning about our shared history and how that has resulted in health disparities that we see in our own province. Providing learning opportunities like this event is one way we're working towards our goal of culturally responsive care for First Nations and Métis patients and families. So it's my privilege to be able to introduce today's first speaker, Dr. Mary Ellen Turpel-Lafond. Dr. Turpel-Lafond is a member of the Muskeg Lake Cree Nation in Treaty 6 territory and was the first Indigenous woman to be appointed to the provincial court in Saskatchewan. She has a distinguished career as a judge and as a children's rights advocate in British Columbia. Dr. Turpel-Lafond is the author of In Plain Sight, Addressing Indigenous-specific Racism and Discrimination in the BC Healthcare. This report was completed at the end of last year and was a months-long investigation into widespread racism in the BC healthcare system. The report comes at a time when increasing attention is being paid to the issue of racism experienced by Indigenous people in the healthcare system. So we're really grateful and we welcome Dr. Turpel-Lafond today to provide some insight into her findings. So Dr. Turpel-Lafond, and I'll turn things over to you.
Thank you so much for that introduction, John. And first of all, I'm just really delighted to be joining this big virtual circle. And I hope you can hear me and see me okay. And we are not plagued by any kind of strange technological problems today. I also want to say thank you. I can still see Elder Evelyn Linklater. So I want to just say thank you so much for that beautiful prayer. It's wonderful that you bless up our gathering and to keep us remembering why we do these things together and gather together. And despite the many barriers that we face as we continue to grapple with this terrible pandemic that has affected Indigenous communities and our families very much. So I'm just really grateful to hear the words of Elder Linklater. And I want to say hello to friends and relatives in Saskatchewan and just to give my very best greetings to everyone. I am Zooming and joining our circle from Lekwungen speaking and Wet'suwet'en people's unceded territories. And I want to just acknowledge that I have the great privilege of working today on their unceded territory. So I'm so pleased to join, and I've been so pleased to be invited to talk to you a little bit about the work that was completed in British Columbia at the request of the Minister of Health, Minister Adrian Dix, and at the request of the First Nations Leadership Council in British Columbia, which is an organization comprised of all the chiefs and leaders in British Columbia. And they together commissioned some work starting in June of last year to look at whether or not anti-Indigenous racism was a factor in British Columbia. at the point of care and whether it was, whether it wasn't, and what it looked like. There had been some allegations of a game being played in emergency rooms about guessing the blood alcohol level of Indigenous people. And so that was an allegation that came forward. So I was engaged to do a review of BC's healthcare system, and I had a small team, myself, another Indigenous woman, Harmony Johnson, and a small group of very skilled people, largely Indigenous people, who came together to do kind of a monumental piece of work. And I'm going to screen share and kind of go through a PowerPoint. I did put a link already in the chat to a summary of the report that we produced that's been appeared recently in the BC Medical Journal. For those of you that don't have time to read the full report, but there are web links to the full report as well, and all of the material is publicly available. So I'm going to just give you a bit of an understanding of what we found. The report that was released was called In Plain Sight. And so it was an independent review of BC's healthcare system to look at Indigenous-specific racism. So there's all kinds of different racisms and discrimination. I'll talk about what these terms mean in a minute to us. But that was very much focused on the experience of Indigenous people in BC's healthcare system. So I'm just really happy today to share some of the learnings from that with Saskatchewan, if they're of value to you. I wanted to start by saying that there is a trigger warning. This is a very emotionally difficult material because the presentation today is like here to help eliminate and expose and do some truth telling about Indigenous-specific racism and promote change. Certainly for Indigenous people participating, this can be a trigger, and the way that I need to talk about this in terms of the findings can be really challenging. So I want to make sure that we have a safe environment, but also indicate that there are some supports. Although these are BC-specific supports, you can use them and you can call for support to these numbers. So it's just important to get assistance because we are dealing with some extremely difficult issues, and they may trigger some memories of your own culturally unsafe personal experiences. So again, the review that was done in British Columbia was a unique situation because we had the full endorsement of the Minister of Health, Minister Adrian Dix, and the government of British Columbia. And Minister Dix provided me with designation under the BC Health Act to have access to all the information that I needed to look at the BC healthcare system at the point of care. So all of the clinical settings. I produced with my team 2 reports. One report on November 30th, which was a summary and a long report looking at the findings. And then in February, a data report looking at outcomes, health utilization, and really the connection between how racism and systemic discrimination affects health utilization and outcomes and systemic issues. So there's 2 reports. They're both available on a website I'll give you a link to. But I just really wanted to focus and to remind everyone here that we were looking at the point of care. And that is important, which is how do people experience care when they seek care? So it's not just an academic inquiry. So in terms of what we heard or looked at, I can first talk about the sort of inputs into the first report. So we engaged with about 10,000 British Columbians. So we surveyed Indigenous people, healthcare workers. We took complaints and inputs to a 1-800 number and an email. And I can say from the time the report was sort of launched, just one second, I'm just going to close my door because my dog is making a lot of noise. My apologies. We're probably going to get photobombed by my dog at some point too. We did surveying and we engaged directly with people, but we also engaged directly with all health professions. So Health Employees Union, Docs of BC, all colleges, all regulators, BC Nurses Union, all First Nations Health Authority. So we had a very broad-based engagement to make sure that throughout the review process, we were able to access information, but also discuss and share information with people across the system, whoever wanted to come forward. And it was a really robust process with a lot of participation and a lot of enthusiasm to actually address some very difficult issues. So we did do an extensive health worker survey. We did do extensive surveying for Indigenous people. We have a survey instrument that probably would be valuable and applicable to other jurisdictions if it was used. And it was designed to be longitudinal to be able to be run again. Obviously, it was quite a process because the Indigenous Peoples Survey, when people participated or filled out the survey, many of them got about halfway through and then they went right to the phone or email to say, I need to give you my actual complaint. I can't just do a survey. So they kind of worked together. We worked really hard to create trust and support with Indigenous people to be able to bring complaints forward. I was also able to deal with complaints inside the BC healthcare system. All of the CEOs of the 5 health authorities in British Columbia and Providence, which is the Catholic Health Authority, all sat with me individually and together. So if issues and complaints came forward, we had a very open and very robust process to talk about it. So it was a lot of collaboration and cooperation is what I'm trying to emphasize. We did not have barriers, which was really welcome and positive. And I'll talk about some of the circumstances about why I think we didn't have barriers. The other thing in terms of data, I just wanted to, you can see on the right-hand side of that screen, we analyzed a lot of health sector data. So health utilization, health outcomes data for First Nations and Métis people in BC. We had some pretty robust COVID surveying underway with First Nations Health Authority and others. We were able to use what's called PREMS data, which is the patient reported experiences measurement survey of emergency departments, which was quite valuable. So there's few data sources we were able to have, and then the new data we were able to generate. We also looked at all patient complaints through both the patient quality offices, which are in the health authorities and regions, but also through all the colleges and through the First Nations Health Authority. So these multiple sources and inputs were important, but having the ability to take complaints directly, to take cases directly, as well as surveying and analyzing how the system is performing, whether or not anti-Indigenous racism is present. This was quite important to be more comprehensive. And I want to speak a little bit about concepts and terms. And I heard the Dean of Medicine speak earlier using lots of different words, inclusion, and I mean, I hear all of these words, which is great. And again, I lift my hands up to those who are working in here. I want to tell you how I use these concepts. And I want to tell you that I found in British Columbia, a lot of the language that is used is not understood. And there is no common definitions or understanding, which is why it's helpful for me to tell you where I'm coming from and how we framed it in our British Columbia work. So this slide shows a couple of things. On the left-hand side, you see the kind of issues we were exploring. So racism. So even the word racism, very few people understand what racism is and how it affects Indigenous people. So racism is really rooted in the idea that a group of people are inferior because of a characteristic, whether it's color of their skin or their culture. For Indigenous people, it tends to be both. So it can be based on color, it can be based on being Indigenous and being connected to an Indigenous culture and identity and community. So the racism comes with these characteristics that are not inherent to Indigenous people, but are inherent to these assumptions about Indigenous people. And that racism can lead to prejudice. So prejudice is a negative way of thinking and attitude toward a socially defined group like Indigenous people, perceiving that they are lesser or what they are. And that can lead to something called profiling. Profiling is where you have a preset idea of how people are before you engage with them. And although racism, prejudice, and profiling are all kind of distinct, they are quite related in terms of the experiences of Indigenous people, and they lead to something called discrimination. Racism and discrimination are different. Attitudes and beliefs and practices lead to discriminatory encounters and exchanges in healthcare. And I'm going to go into a lot of detail about what we found, because we meticulously took this apart, but you have to understand these concepts to be able to engage with them, because there were a certain cohort of people who said, I'm not a racist, I don't want to talk about this. And we're like, okay, whoa, back up here. What is racism? What are we talking about? We really had to unpackage this, even in British Columbia, where there was a lot of support for this review. How this would apply to Saskatchewan, I'm not too sure, but I have a feeling it's probably valuable to unpackage it. Indigenous-specific racism refers to this unique stereotyping, bias, and prejudice about Indigenous people, which is really based in this kind of history of settler colonialism. And it springs from these historic beliefs kind of cultivated about Indigenous people's genetic, cultural, intellectual inferiority, and other concepts that enabled settlers and their governments to, expropriate Indigenous people's lands, put Indigenous peoples in substandard healthcare, like through the separate Indian hospitals, to systemic racism was, of course, used for things like residential schools, medical experiments, etc. So behind these historic practices that we are more aware of through the various truth-telling commissions and exercises that we've had at the national level, we've become more aware of where does Indigenous-specific racism and discrimination come from, right? As we become more aware of it, what we're looking at with this review is how is it present in the healthcare system today, or is it present? The final term you'll see on the left-hand side of that page is the word privilege. Now, privilege is something we well know about in hospitals. People have, they have privileges to do certain things in hospitals because of their roles and the regulations that are in place. But privilege is also about control in the system, and the privilege to manage a system, to hold responsibility, but also white privilege to not acknowledge and address racism and discrimination. And that is a widespread and ongoing issue. So privilege often comes with the same cluster of concepts. I can go into a lot more detail. It's in the report. I think you would find it quite valuable because you will see that this report focuses on looking at racism against Indigenous people, but also the second column, which is anti-racism. So the issues I've just addressed, but let's come to the middle section. The middle section is what mindsets, practices, and tools are important. And I want to focus on anti-racism, meaning anti-racism is actively identifying, challenging, preventing, eliminating, addressing the values and structures, programs, behaviors that perpetuate racism. It's an active state of mind. Okay, you have to be actively engaged in it. So it's a mindset, it's very tool-based, but it has to be grounded in a clear understanding of the main kinds of prejudices and beliefs that may be impairing health services at the point of care. Now, I want to talk about that second tool, which you hear bandied about a lot. Like people will say cultural humility and cultural safety. And they will not define it because they do not have an operating definition of it, which is something I found because we don't have standards. But let me just talk through how I view it. So cultural humility is a lifelong process of self-criticism and reflection. It requires an in-depth examination of your own values, knowledge, and belief about Indigenous peoples histories, experiences. It requires a lifelong curiosity and commitment to understanding the lived experience of Indigenous people of the territory where you are and of the territories where you are. Cultural humility is a mindset. In healthcare, it's being able to hold a mindset that is aware of and understands this history of racism and prejudice, that is humble and self-critical in delivering services. So cultural humility has a unique piece to play, but it is not an outcome. So people talk about cultural safety and cultural humility together and they get it all mixed up. Cultural humility is this mindset that has to be cultivated with anti-racism tools. And as I'm going through this and talking about it, did I see that has been effectively used everywhere? No, it hasn't. We saw in British Columbia, it hasn't. Will this be relevant to Saskatchewan? I don't know. You can tell me if it's relevant in British Columbia. It's probably pretty relevant there because even when I listen to your leadership, those who are the health thought leaders in Saskatchewan, I don't hear them use these terms accurately. So I'd be very interested to learn more. Then when we come to that next line on the slide, desired outcomes. What are the outcomes we're looking for in health What is it that we're pursuing collectively in public services like healthcare? Well, when it comes to the experiences of Indigenous people, we're promoting and addressing substantive equality. So substantive equality is the requirement to achieve a more equal set of outcomes for Indigenous people. Indigenous people will not have the same starting point because of the colonial history I've talked about, because of the second rate and discriminatory, for instance, Indian hospital experience, being given lesser standard of care. Their health disease burden, the health needs for Indigenous people may be more significant, but they need equal opportunity, equal access and opportunity. And we need to close those gaps over time with a reasonable period of time, not close those gaps in like 10,000 years. We need to be able to do that more quickly. And the second desired outcome is cultural safety. So a culturally safe environment. What is a culturally safe environment? Like we talked at the beginning of this webinar, we want to have a culturally safe environment. So if someone makes a comment, they might get booted out of the webinar. Okay, that's kind of a negative definite. I'm glad someone's going to do that because I don't want to be exposed to things. But what is a culturally safe environment? A culturally safe environment in healthcare is a physical, social, and emotionally and spiritually safe environment as defined by the Indigenous patient, where they're not challenged in terms of their identity. They're not put under attack because of their identity. They're not placed into a situation of prejudice because of the ignorance of the provider about Indigenous people's experience, where they do not have a risk of experience racism and discrimination, and they are respected. Indigenous peoples are respected as having distinct languages and identities, distinct rights and experiences, including practices, traditional practices, and cultural practices around medicine and wellness. So safety is a state that you create in healthcare positively by having these mindsets, but also by cultivating it. It doesn't happen unless you cultivate it. And one of the most important findings in the report that we did was the finding that there has been limited success in developing this kind of experience of cultural safety. The final outcome, and I'll speak about this from the BC perspective, Saskatchewan is in a different place on this front. And this is probably important in terms of how we could do this review and why we could do this review. It's also significant in terms of the broader mindset in the political environment that we're in. And that is the rights of Indigenous people. So Indigenous human rights, refers specifically to the requirement that we take measures in our province or our society to ensure that Indigenous people enjoy protection of their human rights in keeping with the minimum standard for the survival and dignity of Indigenous people, which is set out in the United Nations Declaration on the Rights of Indigenous People. And I've included the main article from the UN Declaration on the Rights of Indigenous People, Article 24. So in British Columbia in November 2019, unanimously, the Legislative Assembly adopted a bill, Declaration on the Rights of Indigenous Peoples Act, to bring all laws and policies in BC into harmony with the UN Declaration. That was because we had to use the rights of Indigenous people and ensure that they were protected to advance meaningful reconciliation. So a focus on human rights is important, and it's important in healthcare. So in British Columbia, it is now the law. If you look at Article 24, Article 24, the first part says, Indigenous people have a right to their traditional medicines and health practices. And then it says, Indigenous individuals also have the right to access without discrimination all health and social services. Now, there may be other human rights provisions in the province that also protect you against discrimination, but this protects you specifically as Indigenous people against anti-Indigenous discrimination. That's an important context, and it's quite significant as a backdrop to this report. Secondly, you will see Article 24 of the UN Declaration speaks to the fact that Indigenous individuals have an equal right to enjoy the highest attainable standard of physical and mental health, and states, including provinces, should take the necessary steps with a view to progressively achieving that right. That's that substantive equality outcomes shrinking goal that we have together in the system. So these concepts and mindsets I mean, I'm not going to spend a lot of time because I could go on at length about them, but it is important to have an accurate, robust, and meaningful understanding of what they are. Far too much lip service is paid to, there's no racism, there is racism, cultural humility, cultural safety. It's bandied about with no substantive meaning. Therefore, we're not really actually having a dialogue or a common understanding. So we really wanted to get people on the same page in the work in British Columbia. So moving forward with that sort of background in mind, how we created a safe environment to hear about the experiences of Indigenous people and healthcare workers in the system, let me just tell you what we found. So our methodology and our report is available for you to review in detail from an evidentiary viewpoint. So we found that 84% of the Indigenous respondents reported some form of discrimination that they experienced in healthcare at the point of care. 35% of respondents had witnessed interpersonal racism or discrimination directed to Indigenous patients or their families. So that's the healthcare workers. This was 59% among the Indigenous healthcare workers. 52% of the Indigenous healthcare workers reported experiencing racial prejudice at work. So in the collegial environment in which healthcare is delivered, Indigenous staff at all levels, docs, nurses, all staff that are involved in the delivery of healthcare services had experienced racial prejudice. 42% of the white non-Indigenous respondents reported witnessing racial prejudice toward healthcare workers. So in their workplace, they were bystanders, so they indirectly witnessed it, but they were exposed to it. What's interesting about the surveying is that 13% of the respondents in the healthcare survey in BC, 531 healthcare workers, actually made racist comments in the survey. So they may have identified, like there was a race incident, they identified it, and then they said the racial comment they would make is, but those people drink too much. So it was interesting how healthcare workers were identifying some kinds of racism, but repeating prejudices because they hadn't really fully unpackaged their kind of cultural humility mindset. They hadn't had good anti-racism training. So they were identifying some racism, but they were often repeating. So that told us that there were some gaps here. So what are some of the top reported reasons why racism continues to exist in, for instance, British Columbia? Employees not willing to speak up, lack of accountability by leadership to stop discriminatory behaviors, and that's all aspects of the health professions and the system, an insufficient number of Indigenous health professionals. This infographic, it's kind of like the one infographic that summarizes the entire piece. So I want to spend a few minutes sort of talking about how racism and stereotypes are related to poor outcomes. So in this infographic, you can kind of come in at the 11 o'clock point. You see where it talks about Indigenous systems, knowledges, and practices. And part of the cultural humility mindset is to hold knowledge, hold an understanding about Indigenous people's wellness practices and systems, which were intact in there and worked, frankly, pretty well for a long time. So we come in through the door of colonialism, and through that door of colonialism, we get into these systems of subjugation and oppression based on these beliefs, very intentionally cultivated beliefs about the inferiority of Indigenous people. And I can't emphasize enough that those beliefs were grounded in laws and policies. They weren't just attitudes broadly. They were enshrined in laws and policies that Indigenous and First Nations people in particular were inferior. So that was in the system that created, whether it's the Indian Reserve System, the Indian hospital system, or the residential school system. These are deeply embedded through colonialism. Then we come in through the healthcare system, again, built on segregation, racism, and discrimination. Indian people go to this hospital, not there. Indian people get this kind of healthcare, not that healthcare. So it's hardwired. Racism was hardwired in the system from the beginning. So where are we today? So we come along that wheel. We have to think about breaking these cycles. These cycles do not break themselves. So listening to the voices of Indigenous people, engaging with a mindset of cultural humility will help break these cycles, but we have to have hard conversations. So you come in about that 2 o'clock on that circle, you come into stereotypes. So here in British Columbia, we reported from our work on what are the top 7 stereotypes that we found at all points of care. It doesn't matter what geographic region. You could be in your biggest women's teaching hospital downtown Vancouver, or you could be in the Kitimat Hospital in the northern region. These are the common prejudices and racism we found everywhere. And they are as follows. And again, trigger warning, because they're quite distressing, but they're present. One, that Indigenous, and this is primarily focused at First Nations in British Columbia. So a very strong lens on First Nations. First Nations are less worthy than other patients. They're drinkers and alcoholics. First Nations are drug seeking. In other words, seeking pain medications for conditions they don't have. They're bad parents, a whole cluster of attitudes that Indigenous people can't parent. Indigenous women are not adequate parents. That has also been populated or socialized throughout the system because of the harsh impact of the child welfare system, things like birth alerts, the healthcare system participating with the child welfare system to remove Indigenous children and to intervene harshly with Indigenous families inside the healthcare system. So the whole cluster of beliefs about Indigenous people are just bad parents. That has all kinds of like sub issues, but it's a cluster. We heard a lot that Indigenous people are in emergency department are called frequent flyers. Indigenous people are called non-compliant. They intentionally do not comply with what we say, which is completely untrue, but that's a very common belief, widely circulated. Indigenous people are less capable of managing their health, and Indigenous people get stuff for free. And then a whole package of very misogynistic views about women layered into those other views. So Indigenous women are too sexually available. Indigenous women have too many children. Indigenous women have a higher pain threshold. We tell the story in the report of one Indigenous woman who was undergoing a urological procedure, and she reported to the urologist, like, this hurts. And he's like, well, don't you Native women like it rough? And she was like extremely upset. But so it was in the context of not listening to someone expressing that they're experiencing pain and making a racist comment to the patient. Another example we had for women was Indigenous woman, her partner and a couple of family members are there. She's about to deliver a child. The anesthesiologist comes in to give an epidural. The anesthesiologist, who is an internationally trained doctor, steps back and says, wait, is this going to be one of those Native babies? And they're like, yeah. And they go, oh, that's too bad. In kind of earshot of everyone. So commenting like that. So like these are examples of how the prejudices really come to the fore in the experiences of women, particularly in the reproductive process and care, like antenatal, prenatal, antenatal, postnatal periods. When you then come from the stereotypes, so these are the main stereotypes. So if we had to break them down, like I've broken them down piece by piece by piece, based on evidence by evidence by evidence, what would they be in Saskatchewan? Well, I don't know. Maybe there's no racism in Saskatchewan. I have a feeling that's not the case. But I would be shocked if this wasn't the same in Saskatchewan as it elsewhere, and there could be another 10 items, I don't know. But how do those stereotypes and beliefs drive racism? And this is where people seem to fall down. People talk about racism in the abstract. These stereotypes drive discrimination in the ways it's described about 4 o'clock here. Abusive interactions, physical and verbal abuse. Many, many examples of Indigenous people who are coming into emergency department, they get a security guard and end up getting arrested instead of getting care. There's an abusive interaction right from the point that they're seeking care, especially the urgent care stream. Denial of service. Indigenous people don't get service. These are all the different dimensionalities of discrimination for Indigenous people and how it works out and how it's patterned. Ignoring and shunning. Inappropriate pain management, by often meaning no pain meds, or because of the allegation that people are drug seeking, they're not taken seriously. And it's not until it's a very grievous situation that it's addressed, and a lot of concerns are raised. Medical mistakes. Tell one of the stories in the report of a mom and her daughter who's 10 appear in a northern hospital the daughter's having difficulty. She's an epileptic. She's having some challenges. The staff there persist in asking her if she's intoxicated. Not once, not twice, but 8 times. But were you drinking? Were you what? She's a 10-year-old with her mother. The mother says that's it, like takes the child, leaves that hospital, drives several hundred kilometers away to another hospital and says, I can't take this hospital. I can't take this constant aggression about interrogating us that we're drunk. Goes to another hospital. The child has had a medical problem with her meds. She needs an adjustment. She gets it at another hospital, but that could have been a medical mistake ready to happen by not listening to people or assuming they're intoxicated. And when you're making that assumption with a 10-year-old, it was quite imprinted on the mother and the child about how traumatic that is. And that's not just one trauma. Every time they return for healthcare, they remember that experience. So the idea of cultural safety for them is kind of out the window, right? There's going to have to be a repair to get to cultural safety. So when you have discrimination, you don't just forget about it and walk away. You need to repair to create conditions to provide safe care. And that's the other part. The other thing is disdain for cultural healing. I do know quite a little bit about this from Saskatchewan viewpoint, just myself having had 4 children in Saskatchewan. But I tell the story in the report about an Indigenous woman on Vancouver Island. Cedar is a sacred medicine for Indigenous people from her tribal background. And she's admitted in a hospital. She has some cedar behind her bed because she brings it with her to give her strength and support. It's her traditional medicine. Nurse comes in, takes it, throws it in the garbage and says, we don't allow that in here. Yeah, well, I don't understand what the problem is. Why can't she have her cedar? And does that really necessary to take it off the wall and throw it in the garbage and make that comment? Like, of course not. That treats people like trash. Treats people's culture and identity like trash. And it's disrespectful. And it's something that isn't just saying, I don't like the color of your sweater today, Mary Ellen. That's something really profoundly discriminatory. So disdain for Indigenous people's practices in those, and we saw that sometimes in these arrogant kind of interactions can be extremely harmful. And in fact, she reported, that Indigenous woman reported to me, it was more harmful than the surgery she went through to have that happen to her. The surgery was nothing, and the pain to recover was nothing. That's what was the most harmful thing. She felt totally uneasy the whole time after that happened, not to mention that her traditional medicine was thrown into a garbage can. So those are the main stereotypes and discrimination. But then let's come up, what does that result in? Let's think about the wheel here that we're breaking. We get to 7 o'clock on that wheel. When you have those stereotypes, when you have that discrimination, you then get to less access. Less access looks like what? Unwelcoming environments. That big sign that says, yelling will not be tolerated and you will be removed? For many people, it's like, well, especially if you're Indigenous, you'll get security called pretty quickly. Unwelcoming environments. Lower GP NP attachment, because why do people want to be attached to a GP or NP that's racist and has prejudice and has bias and mistreats people? There's no services there, but when they are there, they're not being delivered effectively. Geographic barriers, because there isn't demand for the build out of healthcare services because the experiences have been so terrible for people. There's mistrust. Mistrust is a really key piece because it's a condition to effective partnering for health. And finally, the final point there, which is tragic upon tragic, is avoidance of healthcare. Literally hundreds of people I worked with my team in reviewing the BC healthcare system said, I would rather die from this treatable cancer than ever going back and getting care in that hospital. I would rather just not get care. I'd rather avoid care for a completely treatable condition than to go because I have been so badly scarred by the stereotypes and the discrimination. So avoidance of healthcare, and that drives a discriminatory attitude on the part of healthcare providers who say, oh, well, they're non-compliant. Well, why are they not complying? Why is your Indigenous patient not complying? Why are they not getting care? You have to look at the whole circle here. Then when you have that access, you come to that final point on the wheel, which is quite something we do study a bit more in like the abstract academic-y, data geeky way, which is the outcomes. Why do we have higher disease burden for Indigenous people? Why do we have higher infant mortality, low reduced life expectancy, higher suicidality and suicidation, higher stress levels, etc.? We can look at all of the outcomes and gaps, but we don't realize the extent to which they're connected to stereotypes, discrimination, and access. So this is the kind of high-level infographic around what we found. Okay, now obviously there's thousands of pages of data and sources, but this is a way just to have a tool like this infographic, which by the way, you're free to use as often as you like if you find it valuable. It is really critical to get at the point of care, those working in a clinical context, to begin to break this down and see how stereotypes and discrimination interact with less access and poor outcomes. And for clinical staff, Indigenous or non-Indigenous, to put themselves in this and see where they are so they can have a mindset of cultural humility. Because this is what is transformative and needed, is to have this kind of awareness and insight that often is missing. Finally, I would just say that the problem that I found in the report was, of course, there's widespread racism, stereotyping, and profiling of Indigenous people. I was shocked by how broad it was, but it's present at the point of care. Racism limits access to medical treatment and negatively affects just racism itself. Quite apart from all of the other barriers it creates, the racism negatively affects the mental health and wellness of Indigenous people in BC. Indigenous women and girls are seriously disproportionately impacted. Public health emergencies are magnifying the racism. COVID-19 and the opioid overdose crisis, Indigenous women are 4 times more likely to die from an opioid overdose. Indigenous people are diagnosed with COVID at a much higher level in BC. From what I can see about public health surveillance data for Saskatchewan, that holds true. The impact is significantly higher, and the disease burden is there as well. So you have is like, then the racism, which again, we've been dealing with in British Columbia and Canada. We've been dealing with these new waves of racism as Indigenous communities are vaccinated. Other people saying, well, why are you vaccinated first? Or you're the purveyor of disease and so forth. So all of the racism that we found at the point of care has been exacerbated by public health emergencies. The 5th point, which I think is really painful and deserves a lot of reflection. I know in British Columbia at the med school at UBC and others, as we develop a new med school at SFU and elsewhere, we're really looking at that 5th point. Indigenous healthcare workers and students face significant racism and discrimination in their work and study environments. And Indigenous nursing, physicians, lab techs across the whole side, they really talk about cultural loading, how as Indigenous people, everything's put on them. They experience racism, they have to explain racism, they have to be the navigators. One doc, who's one of the few specialists in her field, the First Nations woman, talked to me about how, the head of medicine would routinely come by and pat her on the head and say, "You're our Indian, isn't it cute?" These sorts of constantly feeling unsafe in your work environment. And I want to emphasize that was career limiting racism. They documented to me again and again and again, all the staff, Indigenous staff in the healthcare system in British Columbia were able to document to me career limiting racism. So that is not good, to have unsafe workplaces where Indigenous people cannot succeed and advance in their careers with others. And the racism that has nothing to do with anything they have ever done professionally limits them. So I think that is a real moment of reflection for those who are stewards and leaders in the system. We looked at the whole range of solutions that are being used now to address racism, and we found some pretty significant deficiencies. Inadequate training. I talked about the concepts that are not well understood, like cultural safety and cultural humility. Don't forget, they're 2 different things, right? They're very different. Get a good grounding in it. Complaints processes don't work for Indigenous people. Complaints processes are horrific. And I was able to deconstruct a few of them where Indigenous person makes a complaint, then they get sort of a confrontational thing where it's becomes worse, not better. And the Indigenous staff person that raises it, their career gets punished. Insufficient hardwiring of this cultural safety outcome into the system. Indigenous structures and roles in health have to be strengthened. And there's no clear accountability for eliminating Indigenous-specific racism in the healthcare system in BC. A couple of observations from the data report I would share. Indigenous people in BC are receiving health services in an environment that's skewed away from primary preventative care towards secondary and tertiary care. And so the lower, and I know the Cancer Society is one of the sponsors here, so I wanted to put this out. And you're going to say, well, hey, that's probably better in BC than in Saskatchewan. So the lesser access to primary care drives lower cancer screening and higher rates of treatable cancer. So I just looked at it, did the full data analysis in BC. Pap screening amongst First Nations women is only 68% of non-First Nations women. I tried to find some data in Saskatchewan. I think it's closer to 50% in Saskatchewan, but I might be wrong. Someone can correct me. So in BC, it's 68%, yet First Nations women have 1.6 times higher rates of cervical cancer. So, I mean, you can screen, but you don't screen if you don't have primary care that's culturally safe, because there's no continuity of care. People don't have care. It's not being treated well. So we want to address, like an Indigenous cancer strategy, you have to address racism. You have to create a culturally safe environment, and you need to be able to work together with Indigenous communities, Indigenous leaders, and Indigenous thought leaders in health. Second point, the emergency department is the locus for much of First Nations healthcare. Adult user rates in BC are 2 times or more greater than other residents. And that's because they're using as a last resort because they don't have other care. Indigenous women are shouldering the greatest burden. I've talked about a few of these things. Indigenous women report far higher levels of not feeling cultural safe than Indigenous men. So some reflections on quality in the healthcare system and how we define quality. So I view racism and anti-racism as a dimension of quality, even though it's not defined as such. And I think we will move toward new definitions of quality that embed anti-racism. Importance of creating a speak-up culture. And that this event is a wonderful event to do that. So again, my highest gratitude for people to invite me to participate in some way. Experience at the point of care is our primary focus. We need to think about what happens at the point of care. That is really critical. Standards, accreditation, health regulation. We need urgent interim solutions and long-term transformation, and better quality of care is urgently needed for Indigenous women. The report made 24 recommendations to 3 tiers. The first tier is the beliefs that kind of seem to perpetuate or not be able to address this prejudice and racism. The second tier is the behaviors in terms of how we change behavior and how we address the behaviors. Not surprisingly, the largest number of recommendations are about systems. How do we improve systems to address the racism and remove the racism Indigenous peoples have experienced from the healthcare system? So I'm not going to go into all the details, but they're there for you to look up. Reflections on Saskatchewan. Again, these are just my reflections, and I'm not an expert on Saskatchewan health. I do want to stand up Dr. Holly Graham from the University of Saskatchewan. She was an expert peer reviewer for our report, and I really like to thank her for performing that role and for making that contribution to British Columbia in that way. So I was really grateful to have her expertise in nursing and health to be able to reflect on our work. So population health indicators show greater disparities in Saskatchewan in contrast to BC. Health disparities generally there's greater disparity, but the demographics are different. The population is a little different. There is no equivalent in Saskatchewan to the First Nations Health Authority, which is a service agency with a lot of leadership with respect to the entire system and a lot of collaboration. So there are, I know, individual thought leaders. It's just not very systemic in Saskatchewan. It hasn't been well resourced and coordinated. So there isn't a substantial record of innovation yet. From what I can see in Saskatchewan, there's more transition in staffing, and there's limited onboarding training in terms of anti-Indigenous racism or cultural safety. I also would say that from my, again, 2 provinces over viewpoint, and I could be wrong, there seems to be far more limited acknowledgement that racism and systemic discrimination in Saskatchewan connect to the determinants of health and how they impact the disease burden for Indigenous people. I would also say that I do, and again, I'm just expressing a personal opinion here, I do think that blaming Indigenous people for the disease burden tends to be a common theme in Saskatchewan instead of working on the drivers that the disease burden is attributable to. Again, the reports are all available, and the PowerPoint from today, I will ensure that it does get shared with participants for whomever would like to see it. And as I said, I did share the BC Medical Journal short summary of the report. The report has been fully accepted by the government of British Columbia, the First Nations Health Authority, the First Nations Leadership Council, and we are now actively engaged in implementing recommendations from the report. There was just a budget in British Columbia that set aside a lot of funding to try and work on some of these core areas where improvements are going to be needed. But I'm going to stop there as I've probably spoken way too much. And I know we need to take some questions and comments, but I do want to say that I'm not an expert on Saskatchewan. I have close ties to Saskatchewan, and my children and grandchildren no doubt will have ongoing ties. And I hope, if anything, in terms of the methodology, research, or support is of use to Saskatchewan, there's no reason why a similar kind of review could not be done in Saskatchewan, and probably should be done to be rigorous and independent. But it would require the commitment of the Minister of Health, and would require the kind of access to information at the highest level by a highly qualified team. So it isn't something that's going to be easy for one health researcher to do on their own. And it also needs, what's quite critical, is leadership by First Nations and Métis people, respecting and having cultural humility in relationships with Indigenous people from Saskatchewan. So I'll end there and move it over to the discussion stage of our event. Thank you.
Thank you so much, Mary Ellen. Wow, it's so much information to digest right now, but we do have a little bit of time for questions. So if you want to post your questions in the chat, and we already do have one, any tips on having productive conversations with colleagues about their prejudices?
Yeah, I think one of the things, like I talk about speak up culture, I think the challenge is the speak up culture shouldn't be on the shoulders of Indigenous people. The speak up culture should be on the shoulders of non-Indigenous people. So stopping the bystander culture, stopping the culture of tolerating and ignoring or saying, oh, but that's just so-and-so, but especially addressing it where people head teams. And the behavior where there's no accountability or checking, where people are head of clinical teams and they freely express those opinions, and they are not required to be accountable, and people are afraid to hold them to account. So the conversation, like, I don't recommend you go away from this webinar and say, hey, you're my Indigenous nurse colleague, let's talk about this thing that Mary Ellen just said. Like, let's not culturally load Indigenous people already carrying a lot in the system, but let's create the kind of safety needed and the cultural humility needed to have that serious dialogue. So for the first piece, I really recommend cultural humility, which is stop and reflect on what you've heard today. Do some work, make it a mindset. And if you are engaging as a clinical provider with Indigenous people, hold in your mind this history and knowledge and experience, and strongly interrogate your prejudices or bias that you might have, which could have been reinforced through your workplace, your education, the society you're living in. Like, if you have this inclination to think Indigenous people are just drug seeking or they're less compliant or all those stereotypes, stop yourself, right? And don't make it the responsibility of the Indigenous colleague to have to say, by the way, could you stop, right? So that is the piece. I mean, make it safe for Indigenous colleagues to speak up. But don't put this, I mean, the biggest message I got from Indigenous people, and I had this 86-year-old guy who participated in the review, gave me the entire story of all the different kinds of racism he'd experienced. He was also a residential school survivor, pretty awesome guy. He said to me, Mary Ellen, you need to take this racism and give it back to the healthcare system, because it's not our problem, it's their problem. Let them fix it. Why should I have to fix it? He said he's 86. Why should I have to fix it? I've had it my whole life. Package it up in a nice, package for them, deliver it and say, over to you, deal with it. And I thought he was like so wise the way he talked about it, which is give people back the racism. Like, why should we have to fix the racism? That's not our racism. So yeah, so the issue about how to have the conversations, well, management leadership, your thought leadership and health, your system leadership has to have this conversation and make it safe. and non-Indigenous people need to weigh in.
Thank you. And you've provided one of those tools with your report. We do have another question. We'll just do one more question because we have, in some ways, we did want to address that question and arm you all with some tools to move forward out of this presentation. This is just the beginning, it's not the end. And so we do want it to save some time for sharing of those tools. But first, what role or link to the land, ceremony, language can have in addressing racism in healthcare? So what role can that have in addressing racism in healthcare?
Right. Well, I think that's really important. And, like if you're a health professional, say going to New Zealand to practice in New Zealand, there's about at least a week of cultural training that you do with Maori, including going out on the land with Maori and understanding. In the emergency rooms, there might be a team of Maori that assist when Maori come in terms of understanding the culture, the language, the connection. So healthcare professionals, it's just one example, but they have to spend time on the land with Indigenous people of the territory. Why is that important? Because cultural humility is grounded in respecting the territory of the people. So you want to avoid this sort of pan-Indigenous nonsense that we often see, which is, oh, here's like a medicine wheel that applies to all the Indigenous people of Canada. We don't even like you, Nehio, like who are you? Like Indigenous, sometimes in the healthcare system, it's like, well, there's the Indians, there's the Indigenous, like what do we call you people today? And even to just respect the people of the territory by identifying them correctly, spending time in the territory as a visitor to their territory, respecting the Indigenous knowledge of the people of the territory about health and wellness. And again, I lift my hands up to Dr. Holly Graham and others at University of Saskatchewan and elsewhere, and who are here today who are doing that work. But the land-based work is really significant because identity is very connected to land and practices, but Indigenous peoples, like to respect and understand and have cultural humility requires you to do that. And so even in the architecture and the design of your health facilities, reflect that. Like reflect it in the art, work with Indigenous people, like make sure it's the Indigenous people of the territory. Like don't put up a Haida totem pole at the Royal University Hospital. Like we have to, find the right connections and have those proper pieces. But land-based education, one of the recommendations I made was to have an Indigenous medical program. We recently started a program at the University of Victoria Law School. I teach law at UBC, and I'm connected to this program at UVic, where you do an standard law degree and an Indigenous law degree on building Indigenous legal orders and systems. They're both, you get 2 degrees, Indigenous law, mainstream law. It's the only one in the world. It's quite important. It's developing. I'm excited to watch it grow and all the Indigenous people coming and rebuilding their systems and being supported and respected. It's beautiful. And in medicine, that's what we need. We need an Indigenous medicine program because, think about it. There are professors of ethnobotany studying Indigenous medicines in schools of anthropology. They're not in science programs. Like, what's going on? There's no medical program. Like, where's that? So, a place like Saskatchewan or elsewhere, we need an Indigenous medical program with a strong land base. I think that would be a big piece of recognition and acknowledgement with Indigenous people. And I know the Indigenous physicians in Canada have advocated for that as well. So I really appreciate the question about land-based knowledge and how students could feel more safe if that was appropriately integrated as well into practice.
Great, thank you so much. There's some great comments and sharing of experiences, and so thank all of you too for sharing and contributing to the conversation. We're going to switch gears now and listen to Sharissa Hankey, who's a white settler community health clinical nursing instructor working on a master's in educational foundations at the University of Saskatchewan under the supervision of anti-racism expert Dr. Verna St. Denis. So Rissy seeks to work for racial justice by learning her own complicity in colonialism and her responsibility to push for a critical anti-racist lens in nursing education. So we're really grateful to Rissy for joining us and helping us think about what our next step is going to be and how to start the work. Now we've heard from Dr. Turpel-Lafond. What's our next step, Rissy?
Well, first of all, thank you so much, Dr. Turpel-Lafond, for the words you've shared with us today and for sharing your work and your insight on your work. And thank you so much to Elder Evelyn Linklater for your prayers and for carrying us through and your presence here today. And thanks to the organizers for putting this on and everyone for showing up. It's really encouraging to me to see the interest in doing something about racism in healthcare, and I am honored to get to share some of what I've been doing with you. So yes, I am a white settler. My pronouns are she, her. I'm a registered nurse, a nursing instructor, and a master's student. And I hope that today I can honor my mentors, Dr. Verna St. Dennis, Dr. Holly Graham, Dr. Sheila McLean, Dr. Manuela Valle Castro, and Becky Sisakimus-Kuffner, who I'm accountable to, these strong, powerful women who have taught me so much about anti-racism, and I'm honored to be connected with them and to learn from them. And yes, so I have developed some work for the Anti-Racism Network in collaboration with Dr. Holly Graham, and I'm here to share some of that with you today. So on November 30th, when the In Plain Sight report was released, I got to use that right away with a bunch of nursing faculty, doing some anti-racism training with a group of nursing faculty. And so to get to hear more of like the background and the perspective that Dr. Turpel-Lafond used and approached this work with is so helpful for me and such a treasure today. So in this next little bit here for about 10 minutes, we have some time to practice thinking about the harm that we've just been learning about and looking at the report in plain sight, and also trying to assess the harm. So there's another tool that came out of BC through Sanyus, who does cultural safety. It's an Indigenous cultural safety organization in the BC healthcare system. So Sanyus has developed a tool for mapping the harms. So I want to introduce you to that tool and use that tool in conjunction with the In Plain Sight report to try to dig in a little to this harm and try to look at it and maybe dissect it a little bit, try to understand what's happening. So I will start sharing my screen here. Oh, I'm not quite ready for that. Let me open up my right. Okay, so actually before I share my screen, first, we're going to look at one story that's included in the report. And Dr. Turpel-Lafond shared like how comprehensive this, or how many participants, so many people were involved in this report, and voices were heard from hundreds, thousands of participants. And so we're just going to look at one little tiny story, a short one because it's quick to read. It is uncomfortable and really horrifying, I think. And so I want to give a trigger warning that if you don't want to hear about, if it would be harmful for you to hear about this story of racism against an Indigenous person, feel free to take a break for a little bit and come back. It'll take me 1 minute to read this story. So I'm going to put it up on the screen here in case you'd like to read along with me. So this is on page 48 of the In Plain Sight report. So this story says, "They thought I was a drunk." One evening on February 2019, a 57-year-old Indigenous man fell while walking to the bathroom in his home. It was nearly midnight, and he realized he was badly hurt, so he called an ambulance to take him to the nearest hospital where he was x-rayed. Nurses subsequently informed the man that there was nothing wrong with him and that he had to go home. He protested, insisting he was certain that he was injured and couldn't walk, particularly since he had left the cane he used due to a pre-existing spinal condition at home. He says 2 nurses, a male and a female, treated him poorly and made fun of him. They thought I was a drunk. Eventually, as the argument with nurses continued, security was called, followed by police. The man was ultimately arrested and taken to jail for the night. The next morning, he was released from jail, but he was still in pain and couldn't walk. The man was taken by ambulance back to the same hospital, where this time he was diagnosed with 2 cracks in his pelvis. He recalls one of the same nurses commenting sarcastically, "Well, you were able to walk out of here last night." So this story is just one of many, and I encourage you to look at this in plain sight report so that you know these stories, so that you learn what is happening and see this perspective, especially for the people in this gathering who are white, because we have that privilege of ignoring it and it not affecting us personally, but we need to choose, if we want to make this system better and address the harm, we need to choose to look at it and see the harm and try to understand it. So I want to take this story, this one example, and use a tool that Sanyus has developed, which is called Mapping the Harms. So I'll give you a little peek at this document, which came out in 2019, and it is called What Have We Learned from the Sanyus Data? Like I said, this is also in BC and looking at anti-Indigenous racism. And so we're going to use some the ways that they look at harm in this document. If my screen's going to work out here for me. And they use a harms legend. So there's 8 icons. I'm a visual person, so I like having a picture to go with it all. There's 8 icons here about harms. And so I would like, here's my interactive part. I would like you to open up this link. If you're on a tablet or a phone, probably won't work so easily. But if you're on a computer, I invite you to open up this link. And this link should take you to a poll. And it's not a test. It's trying to assess what harm is happening here. And so I want you to look at these harms and click the options that you could see in the story. So did the harms result in death? Were there harms of prolonged pain and suffering? Were there harms of medical complications? Were there harms of family and or community disruption? Were there harms of reluctance to delay in or refusal to access care? Was there loss of autonomy? Were there emotional, psychological, and spiritual harms? Or were the harms kind of wide-reaching and undefined, kind of difficult to pinpoint, but you know they're there? So what kind of harms did you see happening in the story of this man who fell? So go ahead and click. You can choose as many of them as you see. I'll give you a moment here to click on what you're seeing. And we have some results coming in. So people are seeing all sorts of harms. Okay. Wow, 82 people have already participated. And wow, it looks like pretty much everyone can see the emotional, psychological, and spiritual harm, and especially the prolonged pain and suffering. And I think, like, yeah, those are very apparent in the story. So this is one way that we can use Sanyus's tool to look at what the harms are and try to assess the harm that we are seeing in the healthcare system. Sanyus has another aspect of harm that we can try to understand, and they frame it as an iceberg. So here is what that looks like on their report, which you'll be sent the link to this report, so you'll have access to this tool. And yeah, so they have harm happening, like in racist harm can happen at these different levels. So it can be interpersonal, organizational, or systemic. So my other question on the poll is, what iceberg level of harm was the racism happening at in this story? So where on this iceberg was that racism happening? So interpersonal can be, maybe it's microaggression, or it could be substandard care or delayed care. Those are some of the examples they include here. As far as within the organization, that's like, how is the workplace culture racist? How is the racism happening in the workplace? It could be like accepting or normalizing substandard care for Indigenous patients. It could be the grooming of staff to say certain things, or certain things are okay, certain jokes are okay to make, that kind of thing. And then systemic, they talk about the systemic level of change or of racism is, beyond that organization. It's more broad in the culture. And those are the values and beliefs and worldviews, and it can be lack of resources. So I want you to think about what level can you identify in the harm in this story? And I see lots of results coming in. People can see the harms happening at all 3 levels, and organizational is in the lead as the thing that people are seeing the most in this example. And yeah, I think there's aspects of it that hit at each of those levels. So I think it's important for us to be able to look at these harm situations and assess it. I made this into a document that you'll be sent as your homework, because I want to challenge you to take a look at these harms and try to understand them. So we have that legend up here on this document. We have, I have links to those, both the In Plain Sight report and to the Sanyus tool to map the harm. So those are links that you can click on and go to those documents. And then you can work through this table, and you can say what level of the iceberg, which category of harm, how is this harm happening? And then these really important categories over here, this is the last part that I want to go over with you today. What needs to change? How does this need to be different? So in this story of this man who fell and was treated with racism and endured harm, what needed to change? So if you can type into the chat, I would like to hear your perspective. How does this need to be different? What needs to change? Where should the change have happened? Because I think we need to understand this harm and then imagine how it can be different and work towards how it can be different, so that we are creating a better system. Maybe this question is too big. People are taking a while to type it out. Oh, okay, I see. First, listening to the person as an expert on their experience. Intervention from other staff members at the hospital. Oh, well, the chat's going too quick for me to read. They should have believed him. Nurses should have been compassionate. Yeah. So yeah, keep thinking about that. How should this have been different? And then the last thing I want to ask you is, where could intervention have happened in this scenario? So if you were here as a bystander, if you were in the emergency room when this man came in to the hospital, what could you have done? How could a bystander have intervened? Intervene by assigning new staff. Yeah, if you have the power to intervene in that way. Yeah, the police should not have arrested him, but asked questions. Yeah, not brought him to jail. Say, stop, this isn't right. Yeah, so speaking up as a bystander. Right, yeah, so there's so many ways that intervention could have happened, right? And that's the case, I think, with all of the racist harm that we see. So I think this tool, this is your homework. I teach, so I'm used to assigning homework. So this is your homework, especially for white people and for non-Indigenous people who are here today. It's on us, right, to change this. The burden should not fall onto Indigenous people to address the racism in the system. So I urge you to reflect. As Dr. Turpel-Lafond said, we need to do some work. And so here's a little bit of homework to get you thinking about that and practicing. Thanks so much, everyone. You should receive those in an email.
Thank you, Rissy. That's awesome. And I love homework, so we're on. I'm going to give you some more homework, actually, too, or another opportunity to get engaged. And in a moment, we're going to hear from an amazing spoken word poet, Eco-Aboriginal, who's going to close our event. But I'm going to give you the homework first. Work first, then we can enjoy the poetry. So starting on Monday, we have a reconciliation challenge hosted by ConnectR, and I'm just posting some links in the chat right now. ConnectR is a tool that you can use to go and find calls to action and then fulfill and respond to those calls to action. So what we're going to do for the next 8 weeks, starting on Monday, is every week you can choose a call to action from that website or use Rissy's homework. That's some great calls to action right there. And dedicate time to doing that work every week for 8 weeks. So you can join us on a private Facebook page, and that's where people will post what they're working on. We comment on each other's work. We share resources, share events that are coming up that might respond to some of those calls to action. It's a great community all doing the work. And, as Rissy said, as Dr. Turpel-Lafond said, to be anti-racist, we need to be actively engaged in the work. We have to constantly be learning and growing. And this is a safe space to practice some of those conversations so that when we're in these situations of being able to make a difference with our conversations or by speaking out, we have the information, we have the vocabulary, we have the confidence to actively speak out and be good allies. So there are some opportunities to take the work further. You can check out ConnectR and its events page. We also have monthly reconciliation conversations. And these are just informal spaces. Show up for an hour. We always have knowledge keepers and an Indigenous educator. And that's where you can share challenges that you're facing, stories about what you're working on. And it's a nice circle to learn and listen. And on a monthly basis, keep up with people who are putting in their time and doing some work and find some support and community. So I hope you'll follow us on some of those platforms. Now, I want to introduce a really important, beautiful voice to the conversation, Janelle Pewapskonius, or Eco-Aboriginal. I always find that when we're talking about these kinds of conversations, letting the artists speak is so important. Their words are what will change and inspire us. So, Janelle, do you want to say hello and step forward, and then I'll let you take over. There she is. Hi, Janelle, take it away. Oh, you don't have a voice. Uh-oh. And do you want to, how can we troubleshoot this? Do you want to leave it? Yes.
There
Yay!
we go.
Okay.
Hello. Well, thank you, everybody. Dunson, hello, everyone. I have 2 pieces today to offer. I acknowledge the first one is to speak to the impacts of colonialism. And this is a new piece that I created to talk a bit about prairie prairie colonialism or settler colonialism and how this is present in my life and how it feels to try change in order to fit in when we shouldn't have to. And then I want to finish with another piece that talks about the idea of science and energy and how important we all are. So just give me one moment. Okay. This one's called Squares. I've contorted my body, suppressed my curves into flat edges, and I've pressed on my freedoms to find me fitting into these checkerboard patches. I've been shades of green and brown. I've been tilled and scraped for sacred parcels, forming 1 acre just to fit in these prairies, these lands they call home. Are you so proud? I've watched under these clasped hands, between my protector and the curse, making ways for trains and telephone lines in 1867s, my sacred rock formations, now medicine wheels on the bus for your safari tourists, backpacking to see our savage, to meander along these curving rivers, to bushwhack through this thick bush with $5 treaty monies to see the back room of Mother Earth in a buckskin thong, no image, no name, wild hair over faceless face with the words slut and shame, defending every, defacing every one of my daughters, defacing every one of my children. My son is the one, your son is the one who did it. So instead of accountability, you chose the white boy and he made me dance for you. We contort our bodies, accepting reconciliations and liberations and packaged of box tobaccos with pretendians and prendindianisms. The opportunity costs me. It's another day of wondering how much trauma in the name of your anti-racism education. Another son, another question. How am I going to be triggered today? See, my skin is the color of these lands. And these eyes are brown with black soils and sands, and I am the lands. I am this contorted body, a square cut, tattooed in magnetic north and south, east and west, borders and train tracks crossing me. In the violent twisting of my being, am I now fitting into your picture? Am I now valuable? Am I now worthy? This place is so basic, it became a rectangle. Am I not worthy? This is what it feels to be placed in the box, a circle cutting square edges, forcing myself to lose it in the name of fitting into 1 acre. 1 acre, 1 acre, then you take all the acres. Now I am shaken. Am I now worthy? So that one was called Squares. And I recognize that it's came on strong. And I recognize some of the language might be interrupting or feel uncomfortable, but I invite you to inquire as to why it feels uncomfortable. I love my poetry. I love the delivery just now. So I guess if there's room for folks to feel uncomfortable, then that's good. These words have purpose. These words are valuable. And I'm telling this story with care. So please be thankful. This one's to our young women and our young men. See, the grandmothers and grandfathers made blessings for us in this day. Knowing that beyond the ideas of linear in time and space of this human experience, our energy is carried forward to you, bursting through every dimension. See, the very laws of physics know her energy cannot be destroyed. It is infallible. It is indomitable. It is unseen. protecting you as you walk, cascading you as you run, bearing witness as you fall. And even when it feels like pain, you bear it, you bore it, and you know it is bravery. Your grandmother saw you, she prayed for you, you are energy. You've witnessed your strength without knowing you were strong. You were brave when you didn't know it was bravery. See, when she blessed you, she could hear the laughter in her bones, and you bless her with just laughing right down to your bones, and she sees your courage, young one, walking with you. Be it down 20th Street, Sesame Street, or even down Wall Street, these colonial constructs are not the softness under our feet. They cannot carry us. See, the universal law of gravitation states an object attracts another object in the direct proportion of their combined mass and inversely related to the square distance between them. So when you feel the world is getting you down, you have the power in the direct oppositional force holding you up. You are lifted. Queen, your energy cannot be destroyed. See, the law of motion is the relationship to acceleration and the forces acting upon it. We remain at rest until we choose. Be it energy of the motivation or prayer of ancestor, know that when we push forward, we will meet the force in equal and opposite reaction, but we meet them anyway. Our power is our choice. Patriarchy and the forces try to keep us still. Do not let them. Racism and all these negative forces try to keep us down. We will not let them. In moments of quiet, you hear her. That light hum is the moments of darkness. She protects you with her light. Too many are gone, without knowing they are light. They are brilliant with energy. Our very existence surpasses impossibility. See, children, you are energy. You are light, you are love, you are prayer, you are all of it. And so important. I see you. So we love it and protect with it and uplift with it. You're so important. Pass it on. Thank you for your time and energy today. My name is Janelle Eco-Aboriginal Puapskonius. If you figure out how to spell my name, you can find me on social media. For now, have a great day, and I wish you all the best change. Buenas. See you later.
Thank you, Eco-Aboriginal. Wow, what a note to end on. And yes, I hope she does make us uncomfortable in all the ways that we need to be more curious about our discomfort, to let it inspire us to move forward. So I'm very grateful to all of our speakers here today. It's been such a great learning. I'm also wanting to acknowledge Erin Wolfson, right next to me, I think, on her picture there, in the Division of Social Accountability at the College of Medicine, and especially to Christine McDougall, who was really started us off down this path of creating this event from the Saskatchewan Cancer Agency. So thank you so much for all of you coming and wanting to make change and being part of that change. So I'm going to send the computer back to our elder, Evelyn Linklater, here to close us off in a good way.
I want to give thanks for today, for all the learning and continuing our education in a good way. As we end today, I will ask the Creator to give us strength to continue to work together, to love one another, to care for one another. as we should. So in my language, I will give thanks for all of you. You are all important. Nobody is less important. How no tawinan kisiman to, sawidi minana no somo tagama mawiya, sawidi migagirogo to, unigan ni wabuistawa, wista to kabo guys pagosidi mi itatos kiwen dapat kisiman to gigisiwat siwen. Kinanas komit na niya wiya ganun skagis siga, nistay nanas komunan. Hawi go sipit tamats, iwi tamidong tagos niya gitingawi itong tiyak. Aw, mantom, nanas komiten. Aw, ni mantom, tapoy gitse, gigiawi, gigipiwitse, gipisitos kawiya, ano sumutaga mamawiya. Aw, ni mantom, kinanas komiten, igotse. Igose, hay, tapoy gitse, igose. Tinige, hey.
Thank you so much, Evelyn. And thanks to all of you for coming. We hope to see you on that Connect Our Challenge. And all the best. Take care, everyone.